So the topic today is assigned to me is regulatory issues in buprenorphine treatment. Okay, so my scope of my presentation today includes rules and regulations about what are the laws which are involved, maybe some other ethical issues, but not much. But it will exclude anything about processes and procedures, about how to do treatment, or the doses or clinical issues, about assessments, minimum standards which are required. So the focus will be mainly on rules and regulations and the laws associated with that, and not the other issues. So why do we need to be really aware of rules and regulations? It's because of the kind of patients that we deal with, the kind of disorders that we are dealing with. As you know, substances disorders, patients are consuming illicit substances. There are regulations of the facilities themselves where we treat our patients. The medications that we use to treat our patients also are under control. And there are issues related to training, accreditation, etc. And of course, our own NMC Act and rules also govern us. So there are many reasons why we must be really be aware of the need for regulations and what they are currently in our country. So I will jump straight to the NDPS Act and rules. Many of our friends here on the audience and juniors may know a little bit about the NDPS Act, but I will go into some details, but not in full details. And I will try to explain. Please do not read all the provisions; they are not very important. But I will try to emphasize on the salient points. So the NDPS Act is an act to consolidate and amend the law relating to narcotic drugs and to make stringent provisions for the control and regulation of operations relating to narcotic drugs and psychotropic substances. Now, important here for you, many people to understand is there is no real difference between narcotic drugs and psychotropic substances in terms of clinical usage. So for us, they mean the same. They are come under the rubric of psychoactive substances. But when we talk about in legal terms, when we talk about narcotic drugs and psychotropic substances, they are different. And they're not different because of the mechanism of action, but they're different because they're put in different schedules, one, very importantly, and the licenses and procedures which are required to manufacture or distribute narcotic drugs and psychotropic substances are slightly different. So only in legal terms that these two are different. Otherwise, the effect that they have on our brain and our body are virtually almost very similar, depending on the kind of substance that they are. So what is important to understand is that now, when lots of people talk about the NDPS Act and rules, they believe that if a substance comes under the NDPS Act, it is banned. It is not so. The narcotic drugs and psychotropic substances are permitted for use for medical and scientific purposes. You must have heard this term many times. Now, it is not defined as what is a medical use or a scientific purpose, but in common parlance, which we understand, is that medical use would mean for treatment purposes, scientific purposes could mean analysis, it could mean research, it could be many other such issues whereby maybe a laboratory or a research institution is using certain illicit substances to find out certain properties of them. And this could also include forensic laboratories, which also need some kind of a permission from the government so that they can actually possess these kind of substances, whether it is for scientific purposes or not. And also, what is important is that once we understand that there is a permission to use these medical and these substances for medical and scientific purposes, we must follow the rules and procedures that are made under this act. Now, there could be different rules and procedures, which I will go a little bit in detail later, especially in relation to buprenorphine. To emphasize, medications are not banned or prohibited for use. The use is for medical and scientific purposes. The rules under the Act need to be followed, and wherever such a provision imposes any requirement by way of permit, authorization, licensing, that has to be obtained before you use these kind of substances. So in gist, this is what the section means. Now, you must understand the other normal question which people ask is that, okay, chalo, these are not banned, but can we possess them? So according to Rule 66, no person shall possess any psychotropic substance. Buprenorphine is a psychotropic substance covered unless they are covered under the 1945 rules. What are the 1945 rules? These are the drugs and cosmetics rules. So the NDPS Act directly does not actually lay down the procedures for possession of these substances. It is the drugs and cosmetics rules, which I will come to later. So that is what we must be aware of are the Drugs and Cosmetics Rules 1945. Second, what is also important in the NDPS Act is that it allows certain persons to possess psychotropic substances under the Drugs and Cosmetics Rules, and they may possess a reasonable quantity of such substances as may be necessary for the genuine scientific requirements or genuine medical requirements. Again, what does this mean? It means that it allows our patients actually to possess these medications when it is their genuine medical or genuine scientific mean it could be a laboratory or some place like that, which is not governed by the drugs and cosmetics rules, but the NDPS Act allows patients to possess these medications. Otherwise, how else will he may have a prescription, but he is found in possession of say any substance which the doctor has prescribed. How will he say that it is for his own use? The NDPS Act actually allows a person to possess these for genuine medical requirements. So this part is also taken care of in the NDPS Act. The second question which other people ask is about, okay, now I'm allowed to use, I am allowed to possess. How much can I possess? So the quantity which has been described is described as 100 dosage units at a time, provided that an individual may possess quantity beyond this for his long-term personal medical use. So it's about 300 dosage units which is allowed. Now, what is important here is what is 100 dosage units. Now, dosage unit is not defined. So, for example, in say buprenorphine, if you are prescribed 4 mg, 8 mg in a day, or is it a tablet? Is it the daily dose? Is it one-time dose? We don't know. This has not been qualified in the NDPS Act. So it is open to interpretation. Also important to understand here is that there is a special provision in the NDPS Act whereby it allows that these substances may be used for the purposes of de-addiction of drug addicts by government or local body or by an approved charity or voluntary organization. What is important is that it makes a special provision. You see, when we talk about medical usage, it can be for any person who needs these substances. It could be medical cannabis, it could be patients of cancer who may require palliative care treatment. And there are so many examples. It could be patients of rheumatoid arthritis. There are so many, but there is a special provision for the purpose of de-addiction, which is mentioned in the NDPS Act. Now, what is important is that it could be by a government or local body or an approved authority or an organization. So what is important is that this requires some kind of approval or authority where it may be prescribed, not everywhere. It also gives the to the government to establish such centers for identification, treatment, etc. of addicts and for the supply of these substances to these addicts. So again, there is the purposes of de-addiction have been permitted. It gives the government the power to establish these centers. Okay? Again, centers could mean inpatient, could mean outpatient centers. It is not defined. Again, but implicitly, because this law, I'm presuming, has come more than 30 years back, 35 years back, where it was all mainly institutional treatment, which was done. So I'm presuming in inpatient facilities. It also allows the government to make certain rules for the supply, appointment, maintenance, management, and superintendence of these substances, which are referred to in these centers. So for one, the government can make centers, and then government can also make rules related to these centers. So possession allowed, purposes of de-addiction allowed, purpose type, you can make centers, you can approve centers, and you can also make rules related to these centers. So these things are allowed in the NDPS Act. Okay, this is what I was trying to say earlier. The implication of this is that many states have now got their own de-addiction rules, and there are many different standards. And therefore, it is now mandatory to register under these rules if you have an inpatient center. So many states such as Punjab, Haryana, Rajasthan, Tamil Nadu, Karnataka, Mizoram, Sikkim, Himachal Pradesh, Uttarakhand, Delhi, all of them have got their own set of rules, and we have to register under these rules. So these are examples of some of the gazette notifications of different states. Now, in relation to buprenorphine, you see, these are two documents. I am one of the authors of these documents. I mean, many other colleagues and senior practitioners who are involved in making these documents. They are freely available on the IPS website. Please, I will request you to download and read them, and you can always come back to me if you have any queries. These are two important documents which we developed in 2016-17 and one in 2019, which one relates to the legal issues and the other relates to the operational issues. So kindly download these documents. So this is a summary of what I mentioned earlier. I will skip this. It's the same thing which I said earlier. Now, as I said earlier, that we have to go to the Drugs and Cosmetics Act and Drugs and Cosmetics rules to understand whether what are the rules or regulations and laws related to buprenorphine. So when the psychotropic substances, of which buprenorphine is one, is actually regulated by the Drugs and Cosmetics rules. Now, in Drugs and Cosmetics rules, the medications which we use for treatment purposes, please understand the medications that we use for treatment purposes, which are approved by the Drug Controller of India, can fall in primarily three schedules: H, H1, and X. These three schedules cover many medications, and it's a huge list. We don't have to go into the details of all the list, but for our purposes, H1 has buprenorphine and many other benzodiazepines such as clonazepam, lorazepam, alprazolam, codeine, etc., zolpidem, tramadol, all of them fall in H1. In X, for our purposes, there are two medications, which is ketamine and methylphenidate. H has a very long list. It includes practically almost every medication which has been approved by the Drug Controller of India. But for our purposes, we must know H1 and X. So when we talk as from a practitioner's purpose, okay, we know that these are schedules which cover these medications. But what is important? What are important for us is to know whether we can, under the drugs and cosmetics rules, can we procure these medications? Can we stock these medications? Can we dispense these medications? And what is the record keeping and documentation required? So these are the four important aspects which we need to understand when we are dealing with regulations related to any psychotropic substance. But of course, today's the topic is on buprenorphine. But this is important that you must understand whether you can keep clonazepam, whether you can keep alprazolam, whether you can dispense it, etc. So this understanding these rules will help you for other substances also. So drugs and cosmetics rule says is that you are allowed to actually procure medication, and the patients are allowed to, the chemists are allowed to sell these medications on a prescription of a registered medical practitioners. Okay, and when we all know when we use methylphenidate, that is in Schedule X, the prescriptions have to be in duplicate. Okay, one with you, one with the chemist, and one with the patient. So interpret it practically, but in any case, what it means is that it should be in duplicate. And the supply of these drugs, that is H, H1 or X, to registered medical practitioners, hospitals, dispensaries, and nursing homes shall be made only against a signed order in writing, which shall be preserved for the period of 2 years. So understand this. One, the patient is allowed and the chemist is allowed prescription, and he can dispense on a prescription. And you, as a doctor working in either a clinic or a hospital, etc., on a nursing home, can procure these medications only. Please remember, there has to be a signed order. Okay, it cannot be a verbal order. It has to be a signed order. That document has to be kept for a period of 2 years. Very important that it has to be a signed order. It could be an indent, it could be an invoice, it could be anything. Okay. Also, substitution is not allowed by anybody or chemist. They may supply, they're not allowed to do any other this thing. And if you are using a Schedule X substance, the additional requirement is that it should be under lock and key. This is a question which came up many times in the WhatsApp groups about a few days back about whether you can keep methylphenidate or not. So you're actually allowed to keep methylphenidate as long as you keep it under lock and key or a separate place so that safety is ensured and there is no diversion, and in a part of the premises which is separated from the remainder of the premises so that only responsible persons have access to it. For our purposes, because we are discussing buprenorphine today, which comes in Schedule H1, you must understand that apart from the fact that you are procuring it on a signed order, when you dispense the medication, you have to give the details in a separate register, giving the name, address of the prescriber, which you are, the name of the patient, the name of the drug, and the quantity supplied, and such records are to be maintained for 3 years. I will repeat: details of disposal or dispensing, supply, name, address of the prescriber, name of the patient, name of the drug, and the quantity to supplied, and such records shall be maintained for a period of 3 years. Okay, so when you put an indent and request, minimum 2 years required. When you're talking about supplying the medication, minimum 3 years of documentation is records are to be kept. Okay, so as I mentioned earlier, these are our important medications in Schedule H1: alprazolam, buprenorphine, chlordiazepoxide, tramadol, zolpidem, nitrazepam, methylphenidate, and ketamine, and amphetamines come in Schedule X. Amphetamine is not available as yet in India. The third question, which out of the four issues which I discussed earlier, are important for us. I talked about procurement, I talked about stocking. Now I'm talking about whether you can dispense these medications. So Schedule K under the Drugs and Cosmetics Act actually allows us to dispense medications only to our patients. That means you cannot dispense it to someone else or some other doctor's patient who comes. You can only do it to your own patients for which you have prescribed medication. So you can dispense it for your own patients as long as the drugs that you are giving, you have purchased them from a licensed dealer. That is, to avoid black marketing, to avoid substandard or spurious drugs, you must get it from a legitimate person. ऐसा नहीं हो सकता है कि you just somebody says I will supply so many medications to you and you pay him and you write it, given it on writing, but the dealer does not have a license, you cannot do it. So you have to understand that a dealer or manufacturer has to be licensed and the records of such purposes have to be kept. Also, these records will be open to inspection by a drug inspector appointed under the Act. And also they can take samples so that we are avoiding spurious substandard drugs and we are avoiding black marketing diversion. So very important to understand. You can do it, you can dispense, but there are some conditions related to dispensing. Okay, this is again the summary of the medications. They fall under Schedule H, H1X. They can be procured, they can be stocked, and they can be dispensed. There are special requirements under Schedule H1 and X, which I've said about registers, and documentation, record keeping are essential components. And storage and safety need to be kept in mind. So these very five important things you can remember. Now, what are special issues related to buprenorphine? Now, buprenorphine is a very controversial drug, unfortunately. You know what happened is that there are three issues which are important. One is the letters related to by the Drug Controller of India to pharmaceutical companies and to states and UT drug controllers. These are the three important things I will come to. The SEC expertise group recommendations to the DCGI in 2019, and there are new conditions for supply of buprenorphine and naloxone to the psychiatric clinics and hospitals. Three important things which I will tell you. Now, no need to go into the detail. This is just for the sake of highlighting what it is. In 1999, what happened was that the Drug Controller General of India gave permission to one pharma company, okay, a letter to a pharma company saying that you can supply buprenorphine 0.4 and 2 milligrams, okay, as long as it is to the designated de-addiction centers and hospitals with de-addiction facilities. There is no qualification of what there was a de-addiction center. There is no qualification of what is a hospital with de-addiction facility. Nothing was there. They just gave a permission for the supply of buprenorphine. Okay. Now, that was in 1999, almost what, 25 years back. Then what happened? In 2010, please remember, this letter is only for buprenorphine plain. Then in 2010, what happened was that there was another letter which was issued by the Drug Controller of India to UT drug controllers and state drug controllers saying that buprenorphine and naloxone combination of FDC, which is a fixed drug combination, can be supplied to designated de-addiction centers set up by the Government of India, funded by the Ministry of Health, and also hospitals with de-addiction facilities. Okay, now again, no qualification of what these centers are, who can do it. And again in 2014, what happened? So these conditions were laid down. However, you must understand that even after these conditions were laid down, buprenorphine was used by many, many clinicians and practitioners all over the country from 1999 onwards till 2010 and even beyond that. So there was no question about de-addiction centers or any other regulations or these questions which were coming, these kind of regulations which are in use. In 2013 and 14, that is about almost 10 years now, more than 10 years back, this new Schedule H1 came. Okay, this Schedule H1, which allows everybody or every clinic or every practitioner or registered medical practitioner to procure these medications. So what happened is that it was assumed that these letters, which do not have any statutory backing, and this gazette, which actually has statutory backing, it was done, allowed many people to procure these medications. So the number of people who used buprenorphine actually increased after 2013. Now, I'm not going into a debate of what is the letter has legal backing or not, or whether the gazette overrides the letters or not. Not important for our this thing now, but we can discuss it during our session. So that happened after buprenorphine was brought into Schedule H1. Even then, around 2016 or so, 15, 16 or so, due to an increased usage of buprenorphine, this old rule came into force. And people started saying that only the addiction centers which are registered under by the government, only they can use. So many clinics and clinicians who were using buprenorphine stopped using this treatment. And it actually had a major problem, because many of these patients who were actually doing so well on OST and maintenance treatment could not actually use it. That was the biggest problem. So this led to many other unintended consequences, which I will not go today, but some of you may be aware of these consequences. What happened is that because of these problems in 2018, I was also part of this group of Association of Psychiatrists, and we petitioned the government that this thing needs to change. And we petitioned the Drug Controller General of India. And in 2018, we actually were fortunate enough that they invited us for a meeting. And this was the first agenda in the meeting, the Association of Psychiatrists. And we were allowed to make a presentation on changing the conditions of buprenorphine and buprenorphine naloxone tablets. You will be glad to know that I was the one who made that presentation in front of the Drug Controller General of India in 2018. And after that presentation, uh, 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 what happened is that the subject expert committee, there's a subject expert committee for every field, every specialty. They noted and these observations of ours and our presentations, and they allowed that this condition that should be changed from hospitals and psychiatric de-addiction centers to hospitals, de-addiction centers, psychiatric clinics also. So it was a major achievement for us that they allowed this condition of change. Although technically you might say, oh, the law allows us, but there are other issues. The regulatory authorities can interpret whatever they want to do. So, but this was a major achievement which allowed even psychiatric clinics to procure this medication. Also, you must understand is that it was not only based on our presentation only. This internal document apparently was sent to NIMHANS, PGI, and AIMS also to seek their opinions. And fortunately, some of them supported our contention and also agreed that this condition needs to be changed. So this is a very important landmark, I would say, in terms of activism that we were able to achieve. So finally, what happened in 2019? This was in August 2018. It took almost about 7 months or so, 7 months of waiting and hoping for things to change. This final change came. The preparation shall be supplied to psychiatric clinics and hospitals in addition to designated de-addiction centers set up by the Government of India and hospitals with de-addiction facilities. So again, this condition changed. So, but very important to understand, and this I will go slightly divert a little bit, not diversion of buprenorphine, but divert from the topic a little bit. So many people ask this question and about what is this buprenorphine misuse? Has fear of diversion gotten into addressing this opioid crisis? We have the number of people we have, patients we have, opioid dependence in our country is huge, massive. And everyone knows, people working in the East know, people working in the North, Punjab, Haryana, J&K, Himachal Pradesh, Rajasthan, Delhi, uh, Madhya Pradesh. Everybody knows the number of people in lakhs. And total, I mean, the MSJE report is there to tell us how the number of patients. And what is important is this very important paper which said that policies that restrict access to buprenorphine in different settings do not accurately reflect the relative risk and safety profile associated with it, creating unnecessary barriers. So we have actually created barriers, irrational, unscientific barriers for the supply of this medication. The amount of diversion that takes place is mainly towards patients. The patients who want to take it, the patients who want of treatment, it is not mainly for recreational purposes. And the benefits of buprenorphine highly outweighs risks. So two important terms which you will keep listening to. What is diversion? Diversion is the act of redirecting a prescription medication, for example, buprenorphine, from a legitimate source to an illegitimate source or illegal source. So that is diversion. Misuse would mean that the medications are not used according to the therapeutic guidelines. So diversion is slightly different. Misuse of medications is slightly different. There is a slight difference. You must understand whenever you use these terms, what you are meaning when you talk to people, and others can also understand what it actually means. Very important. Okay, usually the sources can be both legitimate and illegitimate. However, you must understand it's usually the end user who is actually on opioids who actually is using this, misusing the OST. It is practically them. It is very few people who use it de novo, and hardly I've seen anyone using it de novo, and hardly I've seen anyone using it more for recreational purposes. Very few people, if there are any, but they would have their own vulnerabilities to use it. But most of them are the end users who are already opioid dependent. So the most common reason reported for intended therapeutic use of OST medication is to avoid ease of withdrawal, is to avoid or ease withdrawal, to maintain abstinence from heroin, and to do self-treatment. So these are the three most common important reasons. Okay, this is what I wanted to try and emphasize, because this question often comes up. Kitni der dein, kyun dein, itni dose kyun dein? See, the patient has come for treatment. You have to fulfill your role as a physician so that you are going to treat his withdrawal adequately, maintain him from maintain abstinence if possible, and also to wean away from illicit drugs. The other issue is that there is insufficient substitution dosage. Many people use 0.4, 2 milligrams, 4 milligrams. What does that do? It does nothing. So for my junior colleagues, I want you to understand there are four aspects to it. Please understand. One, analgesic aspect. Two, easing of withdrawal. Three, decreasing craving. And four is blocking the effects of other opioids. There are four different things. What we do in clinical practice is that, again, I'm diverting a little, last 2, 3 slides, not many. I'm diverting a little bit. But importantly, in our clinical practice, we concentrate only on analgesic effect and ease of withdrawal. We do not focus on reducing craving or the blockage effect that these drugs provide from other opioids. That blockage effect is very important because it prevents overdoses. So please understand this. Four aspects. Important to reduce pain. Important to reduce withdrawal. Important, very important when we are dealing with drug addiction patients, to reduce craving and suppress craving. And fourth, very important, block the other effects of drugs. Unless you're able to deal with these four things, you will find patients who will relapse repeatedly for various reasons. Please understand this very clearly. And the doses are different. Analgesic doses for buprenorphine are 0.2, 0.4, 0.6. For palliative care patients, you have 10, 5, 10, 20 micrograms per week. That is the patch, such as low dose. But when you come to opioid dependence, the doses range from 4 to 24 milligrams per day. Why? Because the doses differ for analgesic versus treatment purposes. So this is a little bit about the document, operational issues about buprenorphine, which we had authored, me and Dr. Atul Ambekar. So the take-home message is this. Addiction treatment facilities are regulated under the Mental Health Care Act, NDPS Act, as you know, Clinical Establishment Act in some states where it is implemented. The medications themselves are regulated under the NDPS Act. They are the narcotic drugs and psychotropic substances. Medications are permitted to be used for medical and scientific purposes. The procedures need to be followed. The medications are themselves regulated under Drugs and Cosmetics Acts and rules, which I said earlier. And under these rules, there are schedules which fall under H, H1, and X. So again, and the NDPS Act is a global act which deals with certain addictive substances. But what are the rules under how do you procure them, use them? You have to follow the drugs and cosmetics rules. And under the rules, there are these schedules which come H, H1, and X. And therefore, these medications can be procured, stocked, and dispensed by medical practitioners, hospitals, pharmacies. Documentation and record keeping are essential, and there is no shortcut to that. Prescription, important. Register of patients, very important. Daily accounts of medications that you're using, maybe stock in, stock out register. They need to be preserved for a period of 2 years. Consent voluntary treatment for buprenorphine, many institutes are using those. You can start making it as a good practice to use consent and voluntary treatment. Privacy and data confidentiality are of utmost importance because this is another problem which is faced by many people. This also comes under the ambit of law, as you already. Thank you.